Thank you, chairpersons, for the kind introduction, and very good afternoon to all of you. I know this is a post-lunch session, and you all must be feeling sleepy, so I would try my level best to make the topic very interesting. At the outset, I must thank Dr. Banshi Sabu, Dr. Amit Gupta, and the whole organizing team for giving me this opportunity. Dr. Manisha and Dr. Goyal also for including me this Diabetes India Foot group. So today I am going to talk about the very interesting subject that we all need to take care of while treating our diabetic foot patients, that is antimicrobial resistance in diabetic foot patients. So I will cover my topic under following topics, subtopics. We all know that diabetes is a cause of real health concerns worldwide, and it has affected almost 529 million individuals all over the world. The prevalence is almost all age groups, as low as below 20 years. Also, I have seen diabetic type 2 diabetic patients. This surge in recent 2 3 decades is because of, we all know, that sedentary lifestyle, which is leading to obesity, weight increase, and further metabolic disorders. It has a significant impact also on the quality of life, and the life expectancy of the affected individual is also decreased because of uncontrolled diabetes and because of poor access to the doctors or healthcare facilities. So, moreover, the diabetes itself is a reason for so many complications, including neuropathy, maybe peripheral neuropathy, or sometimes because of both existing together, that is peripheral neuropathy and peripheral arterial disease, which can cause amputation later in the life. And this peripheral neuropathy is most commonly 50% of the patient are having polyneuropathy in diabetic patients. So the overview of total this the cause of diabetic foot is like that hyperglycemia produces oxidative stress on nerve cells, which leads to neuropathy, and it can affect the sensory motor or autonomic nerves. These kind of patients who already have neuropathy, they have increased risk of infections in any kind of wound, and this cost around approximately more than 50% in these patients, and which can lead to lower limb amputation also, which is the second most commonest cause of amputation all over the world after accident or trauma. And this infection usually occur in these patients because of skin discontinuity, either because of trauma or because of ulcer in diabetic foot. Now, what do we mean by diabetic foot infection? Any infection in the subcutaneous tissue or in the bone below malleolus in any area is known as diabetic foot infection. Now, if we talk about the epidemiology of diabetic foot ulcer, the prevalence is around 6 to 11%. And in a very recent multicentric study from India, it was found that polyneuropathy or peripheral neuropathy accounts for 15% of total diabetic patients, and peripheral vascular disease is around 5%. Two-thirds of the patients of peripheral neuropathy, they may develop foot ulcer later in the course of disease, and 20% of them may require amputation also in the later years. So diabetic foot related sepsis was found to be the second commonest cause of infection related mortality in the total infection related hospitalizations. So it's the figures are really very alarming. So we have to discuss more and more in the such at such platforms about diabetic foot infections and antimicrobial resistance also. The prevalence of peripheral vascular disease is 15% at 10 years, and at 40, it is about 45% at around 40 years duration of diabetes. Now, what about the epidemiology of antimicrobial resistance of diabetic foot ulcer? It has been seen that 48.4% of moderate to severe diabetic foot infections are having MDR bacteria, and and the isolated enterococcus, which is the most common microorganism found in diabetic foot infection, accounts for 37.5%, which is vancomycin resistant. 48.8% of Staphylococcus species, another very common microorganism found in these infections. These are methicillin resistant. 77.8% of isolated E. coli and being ESBL, and 66.7% of isolated Pseudomonas being MDR. And there are certain other factors also which cause antimicrobial resistance, like ischemic. It depends upon ischemic ulcer, whether it is ischemic or not, what is the ulcer size, what is the grade of the ulcer, whether osteomyelitis is there or not, if the patient is having a history of previous antibiotic therapy or previous hospitalization because of diabetic foot infection. These are the different classification. I will not go into detail to classify the diabetic foot infection depending upon the site of the ulcer and infection, depending upon whether it is in the superficial tissues or in the deep tissue, or osteomyelitis is there or not, whether ischemia is there or not. So the most common classification we all follow is Wagner-Magid classification system, where grade 0 is no open lesion or cellulitis, grade 1 is superficial ulcer, grade 2 is deep ulcer up to tendons and joint tissue, grade 3 is deep ulcer with abscess, osteomyelitis and joint sepsis, grade 4 is local gangrene forefoot or heel, and grade 5 is gangrene of entire foot. So there are other classification also, we can follow any one of these. So the basic etiology behind diabetic foot ulcer is that we all know that prolonged hyperglycemia and persistent hyperglycemia is the main culprit. It can lead to collagen cross-linking disorders, cell defense disorders, inflammation throughout the body, decreased inflammatory response also in diabetic patient, and disrupted angiogenesis will lead to defected wound healing in diabetic patients. Here, diabetic peripheral neuropathy may be of sensory, motor or autonomics, where sensory neuropathy causes loss of protective sensations and it may lead to ulcer formation. Motor neuropathy can lead to bone deformity and again may cause diabetic foot ulcers. Autonomic neuropathy, which is often missed by many of us, it should be definitely examined in every patient, and it can cause dry skin, no sweating and skin fissures, and it further causes diabetic foot ulcer. Peripheral arterial disease, if it is there, atherosclerosis may be there, increased oxidative stress may be there, and inflammation in lower limb microcirculation, ischemia will be there, and it can lead to diabetic foot ulcer. But there are certain other risk factors also which are predisposing factors for the development of diabetic foot ulcers and further infection. Even in a normal individual without any polyneuropathy or without any complication, if there is sustained hyperglycemia and any of these predisposing factor, it can cause diabetic foot ulcer and further diabetic foot infection, like BMI increase, like increased HbA1c, or ulcer course, ulcer size is there, is more. Peripheral neuropathy, if it is there, it is definitely is a predisposing factor. Peripheral vascular disease, if osteomyelitis is there. Peripheral blood leukocyte count is also a predisposing factor for causing a diabetic foot infection, and neutrophil percentage also is a culprit behind it. Use of antimicrobial drugs within last 3 months may also lead to diabetic foot infections. These are the microorganisms which are commonly found in diabetic foot infections. Staphylococcus aureus and beta hemolytic streptococci are the first microorganism to colonize in any acutely infected bricks, and there are certain other factors which may develop more and more microorganism in diabetic foot ulcer. In chronic wound especially, there are polymicrobial microbiota including gram-negative rods and anaerobes also. The most common bacteria detected in diabetic foot ulcers are there, like gram-negative bacteria, Pseudomonas, Streptococcus beta hemolytics, Proteus. Gram-positive is Staphylococcus is the most common, Streptococcus beta hemolyticus. Anaerobes these are the certain other bacteria which may occur in diabetic foot infections. So this is the percentage of multi-drug resistant organism found in diabetic foot infections, and there are certain typical features of each of these microorganisms depending upon. Certain are more common in superficial wounds and certain are common in deep wounds also. also. So what is the basic reason behind antimicrobial resistance is the mostly due because of inappropriate antibiotic treatment, reduced antibiotic concentration in the tissue, or maybe chronic course of the wound, reduced effect of antibiotics in the wound environment, and frequent hospital admissions of diabetic foot ulcer patients which are likely to be exposed to MDR organisms. There are also reports that inadequate selection and abuse of antibiotic may also lead to the development of antimicrobial resistance in these patients. And there is an exchange of resistance genes also called as integrons, which may cause antimicrobial resistance. Just 1 2 slides more.
Yeah, okay.
Biofilm formation is also a main leading cause of antimicrobial resistance, which accounts for 60 to 80% of chronic wounds. And this is the most difficult thing to identify between infecting and colonizing bacteria, because of which there is because of misidentification of bacteria, there is inappropriate use of antibiotic, and this can lead to antimicrobial resistance. Sessile cells also show a higher tolerance towards antimicrobial agents, and this is also one of the major reasons of antimicrobial resistance. We can identify very well a formation of biofilm if we see certain things like recurrence of the infection of the same microbiota in the same ulcer, or negative cultures in spite of proper technique of sample collection, or maybe because of there is a medical history of implant, or secondary infections like signs of secondary infections like fragile granulation tissue also. These are the mechanism basic behind antimicrobial agent tolerance, where the most common is inability of drugs to
Okay, ma'am,
penetrate through
can we
the
finish?
polymetric
Yeah.
constants. So coming to the to summarize, just to summarize my presentation, bacterial resistance in diabetic foot infection is a growing global concern as it hinders treatment and increase the risk of serious complication such as the need for amputation and mortality. Therefore, it is crucial to focus on studying the susceptibility of bacteria to antibiotics to ensure appropriate prescription doses in pharmacological treatment and to avoid overuse of these medications. Understanding the resistance and sensitivity of bacteria causing diabetic foot infection is essential to guide the choice of antibiotics and ensure effective treatment. Furthermore, it would be pertinent to consider the assessment of fungal infections also in future research endeavors. This inclusion would contribute to a more comprehensive understanding of the microbiota implicated in these infections, further enriching the scope of the research. This will help optimize clinical outcomes and reduce complications associated with these infections. Continued research and data updates on bacterial resistance are necessary to adapt therapeutic strategies and effectively address this public health challenge. Thank you so much for patient listening.